Our goals for today will be to share the program status updates, our progress towards key implementation activities. We would review and overview the first year case rates and answer any payment-related questions. We would review programmatic refinements that were made in response to some of your feedback, and we would answer questions that you may have regarding the Maternity Payment Bundle Program. So for some program status updates, some things we recently accomplished: we completed the actuarial modeling and program testing. We drafted case rates, provided historic performance reports. We also have some provider resources, video guides, frequently asked questions, quality measures guide, and billing examples, and consideration of program requirements. Some of our current priorities: DSS has provided all the maternal bundle practice providers with their final case rates for year one. These letters were sent out on Thursday, October 31st, and we shared 2 new provider resources, the 835 test files and encounter form templates in response to requests from providers. DSS also made great progress towards obtaining the state plan amendment approval in October by formally submitting the state plan. Since the state has been working with CMS informally over the past 2 years, we expect to obtain an approval relatively soon. Also, in the near future, we are planning to publish the provider bulletin for this program and share the test files for the supplemental payment report, which we will provide to support accountable providers' ability to attribute at the TIN level payments among its providers and practices. So our upcoming initiatives would include test files for supplemental payment reporting and performance year provider reports. At this point, I will hand you over to Grace to continue with the presentation. Thank you.
Thanks, Fatmata. Hi, everyone. I'll be going over our performance year one case rates, which have been shared with you all not long ago. So as you're aware, in March of this year, we've shared a draft version of case rates that was based on an older period of time where we identify deliveries and look at all the claim history to develop those case rates. And afterwards, in August this year, we also share some supplemental information, in response to some of you all's questions on some specific, attribution, design, things like that. So those information should have already, been shared with you all. And just to know, those are based on the delivery year of 2021 to 2022, meaning delivery incurred between October 1, 2021 to September 30, 2022. And most recently, as Fatmata mentioned, at the end of October, we shared a refreshed version. So these case rates are based on deliveries between October 1, 2022 to September 30, 2023. So these case rates also reflect some programmatic changes and we've made based on some of the feedbacks we've heard, and we'll outline those changes in a later slides. So DSS will keep monitor the changes in member access, practice revenue, and billing patterns after the program implementation to ensure that the rollout of case rate payments occurs as designed and to preserve Husky Health members' access to care. And that is obviously to protect members as well as providers. And after year one, DSS will rebase the case rate, and we will do so at a less frequent cadence than once every year to account for the changes that potentially could happen regarding member risk mix or the type of service or the service frequency over time. Next slide, please. So here is sort of a example of, the table we've included in the letter you that shared with you at the end of October. Again, this is a newer period of time we've used, and as highlighted here, it's based on delivery between 10/1/22 to 9/30/2023. And all the case rates and information summarized in this table will be for per 10. And those case rates that will be paid will have no difference among different AVRS, but it will be the same exact rate for each of the practice. So on this table, the first row identifies your practice name, your billing tax ID, as well as your Medicaid ID that will be receiving payment. So sometimes for some 10, there will be various AVRS, but we looked at 12-month period and identify the AVRS that has the highest revenue received. And that is what we default to be the AVRS that will receive all of the case rate payments. On the second row, we first share the attributed episodes. So those are the episodes we have identified to be under each practice's care for the continuous period of time. So you all should see numbers that's above 30, as that's what we consider the threshold for accountable providers. Then the second part is the trimester 1 fee-for-service payment. So those are the fee-for-service payments made for these attributed episodes during their first trimester. And we only included costs that's related to maternal care defined by the case rate codes published on the site during first. Obviously, those payments will still be reimbursed, even after program go live through fee-for-service arrangement. Then in the second trimester, third trimester, delivery and postpartum. So during this period of time, obviously during the study period, they're still reimbursed fee-for-service, but those are the payments will likely be covered by case rate after program go live. So the first part shows the total cost for all of the attributed episodes. And then we also indicated the average cost per episode during this period of time. The next cell to the right, we indicated the average month of payments we believe would have been made for those attributed episodes on average. And then the cell to the right indicates what's the year one case rate will be like. So again, those are payments will be made per member per month after triggering. Then the cell to the right is a case rate add-on payment. So some of you all will receive $7 PMPM. Some will see $21. So for the providers who chose to opt out of doula, you will only receive $7 add-on payment for the lactation support. But for the practices that opt into the doula program, you will have the full $21 add-on payment PMPM. But that $14 add-on for doula will be, subject to reconciliation at the end of the year. Then the last cell to the right indicates the total payments will be made per member per month with the add-on. In the next two slides here, in slide 9 and 10, there's some, definition we included in the letter to make sure you can have the opportunity to look into a little bit more details for each components we've shared, and let us know if you have any questions there. Right. As I mentioned, we did share those draft case rate in March, and then there's this new version of case rate. So after the March case rate was shared, we did receive quite some provider feedback, which was awesome. And then we evaluated them and then made some technical adjustments to the program to take into a lot of good considerations. So the first thing we did change was to exclude services billed by family medicine physicians and family nurse practitioners. So as I mentioned, the case rate only covers services that's maternal care related and are billed by maternal care providers. We originally thought or identified family medicine physicians and family nurse practitioners that could potentially also bill or provide services related to maternal care. But after hearing feedback, for the most part, these two type of providers only provide services that's irrelevant to maternal care. So we decided to put these two specialty type back to fee-for-service arrangement, and our case rate will no longer cover services billed by these two type of provider specialties. The next change we've made was to exclude episodes that have for members that have other insurance coverage. So we've received feedback about the billing, misalignment with what other potentially commercial insurance requires to use global codes. So that definitely, understandably, will cause some issue with trigger. So we respect that, and we said, okay, for all the episodes that indicate members that have any kind of other insurance coverage at any point will be excluded from our case rate calculation. However, after program go live, and during any month when the system identify member has another insurance coverage, those months will automatically return to be reimbursed fee for service. And then after the members, for some reason loses their other insurance coverage, they will be allowed to re-trigger and start to get the case rate payments again. For another update we've made is to allow place of services for the triggering events to happen not only in the office setting, but also in the off-campus outpatient hospital and on-campus hospital, right? In the initial draft case rate, we only allow triggering to happen in the office, but after hearing feedback, sometimes those services, especially MFM related services, could also happen in the off-campus outpatient hospital or on-campus outpatient hospital. So now all these three places of service will be able to trigger the case rate payments. The next change we've made is to remove some of the comprehensive preventive medicine E&M codes from the triggering codes. So, because this was, we received feedback about these codes mostly are for the annual physicals and they're unrelated to maternal care. The last change we've made is to identify those provider acquisition that will be, happening in the near future. And we combine all those experience into developing the case rate. For example, if a provider A will be merged or acquired by provider B, both of their historical experience will be captured to develop provider B's case rate, knowing all of the, the patients will be carried over to this provider B. Okay, next slide, please. So next we want to, talk about MFM, as this has been a hot topic. So after carefully, considering all the potential operational and actuarial consequences, DSS has confirmed the decision to include MFM care within the first year of maternity bundle program. So this is mainly to, align the design with the goals to align incentives across OB provider specialties to ensure the inclusion of those higher risk patients in the program and to reduce complexity in program design and operations related to MFM billing and the impact of attribution changes. Because of this, we also shared additional information in the letter you should have received. This is because we understand as MFM, providers have probably a different billing or service type, and we want to make sure some of those revenue distribution challenges can be helped. We provide those supplemental data to indicate in the case rate how much of the services were actually performed by MFM. So we'll go over that in the next slide. But we do also want to note that in recognition of those feedback on this topic, we will continuously review and reassess those MFM impact, over time, and then see if there's any changes that need to be made. Next slide. So this is a table, some of you, so because for among the accountable providers, some of you have had a MFM historically, some of you don't. So for the practice that don't have MFM historically, you won't receive this information. But if you do, you will have this table included in your letter. So the first part of this table are, same with the table before, that just indicate the total trimester 2, 3, and delivery and postpartum fee-for-service payments that were used for the case rate development. The second part is among these payments, all these, prenatal and postpartum care payments, what are the services cost for those, provided by MFM? The last part is the percentage, right? So percentage of services that done by MFM. So hopefully by using this information, it might help, some of you guys is to, decide the revenue distribution. We did also include some key terminologies for this table just to make it clear what those numbers mean. Thank you. Last thing we want to note is that on both tables on the right corner, top right corner, you will see the payable provider AVRS. Obviously, like I said, those are identified by the highest revenue received AVRS. But if you prefer to use or receive those case rate payments by a different AVRS, then please share with your CHNCT representative, and we will definitely reflect your Medicaid ID of choice to receive the payment in the system. And please share that information by November 15, 2024. Right. Thank you. I will hand it to Tiffany to talk about programmatic refinements. Thank you.
Thanks, Grace. So like Grace mentioned, we just wanted to announce and share a couple small technical adjustments that were made in response to provider feedback or questions that DSS received. So the first thing we wanted to announce is new trigger event guidance for Go Live. This update is being responsive to feedback around how providers would be reimbursed for patients who are later in their pregnancy at the time of the program's January 1st Go Live launch, particularly for triggering the case rate for patients in their third trimester upon Go Live. So based on reviewing actuarial assumptions and testing operational feasibility, DSS has decided that for the first quarter of the program, DSS will only allow trigger events in the second trimester to initiate case rate payments. And this is being done to ensure that for those first 3 months, it's going to allow the provider to receive case rates for the full duration of the episode. This change is limited just to the start of the program, so the first 3 months, and does not impact the case rate amounts themselves. These rates have been based off of each practice's historic utilization, which basically means that different practice patterns around patients who seek care or change care later in pregnancy or during postpartum, those kind of practice patterns have been factored into the case rate already. What this means for providers is that effective January 1st through March 31st, trigger events in the second trimester only are going to be able to initiate case rates. So you would not be able to receive the case rate payment for patients who are in their third trimester or postpartum period in the first 3 months of the program, giving you guys this time to transition into then being able to trigger the case rate starting April 1st for trigger events in the second trimester, third trimester, and postpartum period. And I will just pause to say, if there are questions, you're welcome to use the Q&A feature. That can be found by clicking more, or I'm happy to also stop and pause for questions if folks want to raise their hand as well. David?
Sorry. So if you have somebody who started in the second trimester in November, so 2 of the 3 months are November, December, and then they have a visit in January, is that going to now qualify for the case rate, or is that going to because we're gonna probably put that diagnosis code on in second trimester, but we're now 2 months in instead of the first of the 3 months. How's that gonna work?
I believe you would still receive, initiate the case rate in the second trimester,
So
just based on that diagnosis code that you'd be putting on.
would we get paid how does it, so it'll just start the 9 months of payments at that point?
I think it wouldn't be a complete 9 months of payment. It would just start based on the number of payments remaining for what would have been the time frame of the episode. So say if the case rate was supposed to start in the beginning of the second trimester in November, then you would only get case rates instead of 9, you would get 7 for the remaining period.
Right, but since we can't build a global anymore, we're losing out on 2 months at that point.
I think you can build the
Fee for
the
service.
E&M. Yeah. fee
Yeah.
for Service.
Can bill fee for service for the first 2 months.
Right, but I understand that, but we normally historically never built fee for service. We always build the stat code because we knew we were getting a global payment. And now it's hard to change. I mean, we're working on changing our system for 1/1, let alone for 11/1. And now that could put us behind the 8 ball at this point. So I don't know if there's any kind of other reconciliation that can happen to address that after the fact. Because I think we will have, we're caught in the middle at that point.
Yeah, David. So if you don't mind me chiming a little bit here. So Tiffany, if you don't mind going back to the slides I was talking about case rate. I believe that's slide yep, right here. So in your letter, you will see there is this part in the middle say average month of payments per case. So I don't believe any practice had 9, right? So we did factor in the potential start of the episodes being not the first month of the second trimester. So your case rate is actually factoring some of the, the care being interrupted or start late historically, and we did not account for those incidents to be part of the, the case rate denominator. So let's say so when we identify historically the case rate, the denominator here, we did look at, the services that's maternal care related, which is on that case rate code list, and when that first billing comes in. So I don't believe there's a lot of episode where there's absolutely no prenatal care billed historically. That's why those episodes or those denominator here is not 1 or 3. That's super low, right? Those usually have, about 7-ish, or it varies obviously, but there are billings that happen prenatal. So I just want to note that we did not assume there's going to be 9 payments for everybody to begin with. So I can see why you might have some concern, but I do want to make sure we factor those interruption of
But I think you came up with a case rate based on
care or
total
late start
payments.
into our calculation.
Right, but I think you came up with total payments based upon all the payments and the number of cases, not the number of months. So you define the case rate based upon the episodes and the total dollars spent.
For all
Now
of
you're
those
breaking, like, so if we're not going to get paid the full case rate because it's all, because we missed 2 months because it started in the previous period, we are shorting ourselves. Because you're effectively paying us over 9 months to pay us month over month
We
over
are
month.
not.
You picked
that we're not paying over 9 months. So if here your number is 7, we're assuming we're paying you over 7 months, not 9 months. I don't know what's your practice's number here. Let's say if it's 7 months, we only assume that this full second trimester, third trimester delivery postpartum care are going to be distributed in 7 cadence, not 9 cadence.
And I do believe there might be an opportunity if you were to initiate care earlier, perhaps make sure postpartum care is continued, then you would be able to get up to 9 payments. So that's an opportunity to increase earnings there.
So I'm just going to use a very hypothetical example, right? So if there is a member that's under your care, you've been using global code only. You don't bill anything prenatal or postpartum. Let's just assume there's that example. What happens is that we will assume this full global code service cost will be distributed through 3 cadence, only 3. So that denominator here will be counted at 3, definitely not 9. Because of how we, our design of the logic, we don't assume 9, we assume 3, if that's the example.
Yeah, I guess so. I'm trying to think through, like,
Understand, David. So the reason
I don't know how many months we're going to get paid. I think that's the problem. Like, if we start it right on, because you have to account for 3 months postpartum, post delivery as well, right?
Yes. You will get postpartum payments, right? So in your example, if that's the January is the last month of the 2nd trimester, you kick off that case rate payment, you will get 7 payments, for including that 3 months of postpartum.
Yeah,
And
visualizing this, because we haven't seen it happen, is really difficult.
Absolutely
because it's a
understand.
lot of it, we hadn't, all we built was a global code before. And yes, you've added MFM, but that isn't always part of it, but every case. So it's sort of, we're flying a little bit blind, and you can appreciate that as well.
Absolutely understand. Yep.
And we're trying to make sure we're not losing money at the very minimum.
We definitely building a lot of conservativeness in our logic. So, for like I said, understanding, historically, there hasn't been a lot of trigger. So when we count for the case rate, we actually looked at any of the case rate, payment list. So the code will account all those services as part of the denominator and potential cause or triggering of the case rate payments. Sorry, I might get too much into details, but we definitely, what I'm trying to say is we're building conservativeness when we calculate the case rate. And as Tiffany mentioned, it definitely opens up a lot of opportunity to start this case rate. As I said, we did not assume 9 payments. That's the bottom line. We did not assume 9 payments. We assumed, however many we indicated in your table, but there is definitely opportunity for you to get 9 payments. If you start the care and billing trigger payment or as early as the 1st month of the 2nd trimester, then, let's say if you continuous billing, you could keep up with the monthly checking or whatever you got to do with a patient, you bill correctly, you will get 9 months of payment. So that 7 become 9.
The cultural. Hi, this is Charles with Mercer, as well as the shift to billing E&Ms and fee-for-service for the first 3 trimesters. There's upside there, as well as we looked at the case, the global case costs.
Yep.
And David, the door certainly isn't closed. DSS is going to continue to look at things. We'll always invite a conversation specific with you that could dive into your details a little better than we could here. That could help maybe parse through a little bit of the confusion or the transition difficulty that this program is going to bring.
Okay. Thanks.
Thanks, Charles. Thanks, Grace. All right. Jumping back to program refinements, the next minor updates we wanted to add a little bit more guidance around pay for reporting measures. So as a reminder, this program has 10 quality measures measuring performance, 5 of which are pay for performance. Those are based on outcomes. And then the 5 listed on this table, on this slide, are pay for reporting outcomes. Each of the measures are weighted And that's going to help DSS calculate a quality score for the practice. The quality score is going to be based on the practice's overall improvement year over year, and then also their performance among peer practices. So with that being said, one of the first updates we made for the pay for reporting is around number 8, doula utilization. For this measure, DSS is not going to require practices who have opted out of receiving the doula add-on care payment to report on doula utilization, since they're not receiving that. And therefore, for practices who have opted out, the measure weights have been re-weighted in the second row to about 7%. We also wanted to call out for these pay for reporting measures, 2 of the measures, number 6 and 7, will be collected through claims data. So nothing's really needed from practices on that end. But for 8 through 10, those are going to be, we're asking practices to submit encounter form data through the encounter form, which was recently posted and shared with providers. This is going to be pretty similar to the OBP4P program encounter form. So hoping that familiarity eases the transition for providers. For the first, for the doula utilization measure, number 8, DSS is going to require 100% encounter form submission to meet the criteria of saying that practices have reported for this measure. And then for number 9 and 10, breastfeeding and behavioral risk assessment, DSS will require a 90% encounter form submission to meet the requirement for reporting for this measure. Additional information on the quality measures themselves can be found in the quality measures reference guide. And like I mentioned, we also posted the encounter form so you can start to see what that would look like. The last technical adjustment that DSS made was in response to provider questions around the CARC code. So as a reminder, once practices submit a claim with the trigger event, that trigger event claim and all subsequent claims will be zero paid. The DSS system is going to assign a unique EOB code on the remittance advice, and the 835 will also contain a CARC code indicating the reason for that zero claim payment. And so DSS originally proposed using CARC CO97, but there are some questions about the use of this code, and so DSS conducted a provider survey to request input on whether to change the CARC, whether to keep it at CO97 or change it to the proposed alternative CO245. Based on survey results, most participants indicated that they preferred the change to the new CARC code, or they didn't mind it, so they were good either or. So based on that response, DSS has updated the CARC code to 245. Like Fatmata mentioned, we recently released and shared a sample 835 test file, so that's where you'll see that CARC code there as well. And I just wanted to call out one other update or one other question shared as part of the survey that was asked. This went out to all providers. There was a question in terms of the supplemental data report. So for the case rate payments, there's also going to be a supplemental payment file that accompanies. This is going to give a little bit more information on the claims payments. So that file can be accessed. The survey results showed that most providers wanted to have all providers under their accountable TIN to be able to access that report. So that's what DSS is going to do. It's going to be pretty much available to anyone who can access the provider portal.
Tiffany, can I just clarify one thing? So the supplemental report, it won't be the claims, it'll be the case rate payments.
Thank you. Okay, perfect. So just to close out, wanted to just give an overview of the different provider resources that Fatmata mentioned at the beginning that's available to providers. So that it will include the sample 835 test file, the sample encounter form. Based on the recent technical adjustments that I just went through, we've also updated the program FAQ, we've updated the quality measures reference guide, and an updated code list is also going to be posted all on the DSS website. The link is included here, and these slides will also be posted. And then as a reminder, if you would like to change the Medicaid payable ID that will be receiving payment for all your case rates, please request that change to your CHN Provider Engagement Services representative by the 15th of this month. So with that, we will take some time to answer questions. Again, feel free to chat them in the Q&A, or we'll also call on you if you raise your hand. Denise?
Hi, I just want to clarify what was being explained to David. So if the patient is in month 4 for November and month 5 for December, and then month 6 is January, when we bill January and you see the trigger code, the case rate is going to start in January. What is the expectation that we're going to do for November and December? Is the expectation that we're going to go back and bill fee for service to Medicaid for those services? Or are you saying the money from November and December will be rolled in and your case rate for like January, February, March, the remaining will be a higher number than you anticipate?
Thanks, Denise, for the question. We're not changing case rate. So whatever you get, no matter the trigger starts in January for the last month of second trimester, or if, you know, the case rate starts in January and that's for the first month of the second trimester, the case rate will be all the same. So each, like I said, each TIN will have one case rate, no matter when the trigger starts, you know, whatever the case is, it's going to be one TIN, one case rate for the whole year.
Yeah, I think
Okay.
Denise,
So
in your
then-
example, the case rate would have started in November because it was second trimester. What we wouldn't have done is started somebody in the third trimester.
So we would actually capture the revenue for November and December in January. You would backdate us and pay the case rate for those 2
No,
months?
it would pay in November for that individual. What we wouldn't do is take an individual that was in third trimester in November, or let's say January at the start of the program that's in the third trimester, and create an episode and create a case rate for that person. We will delay it for everybody that's in the third and allow them to complete fee for service so that the attribution rolls in with more months and you don't get caught in a position where you have a third trimester individual that's only one case rate before delivery, or, you know, is case rate contingent in the same month as delivery. And then you only receive one case rate payment for that individual. Instead, we're going to allow those individuals essentially to pass the program and remain fee for service unless they were second trimester in November, or excuse me, in January.
So in January, when the trigger code, sorry if I'm not getting this, when we bill the trigger code in January, you're gonna give us a case rate for November and December. That's what you're saying?
No, sorry. So the case rates would start, if that individual's still in the second trimester, the case rate would start in January, and fee for service would be paid for November and December.
Okay, so we would need to bill E&Ms for November and December to get fee for service, because right now those bills are not going out the door in November, right? We're not billing fee for service in November. So the expectation would be that we would go backwards for those 2 months and bill fee for service.
Correct.
Okay, and then
When
when I'm,
you bill in December and when you bill in January for services in December, you would still go back to any service date in November, December as an E&M fee for service.
okay, because right now the November charges are coming in because it's November 5th already. So those come in as 0502F, which do not go out to Medicaid at this time because they're category 2 codes. And then, but we would have to change that to an E&M code to force it to Medicaid, but we wouldn't do that until January. That's what I'm hearing.
I think the technical application of that's a bit beyond my reach. I'm not sure if MedOps can opine on it. If there's a certain billing procedure or the methodology that needs to be discussed, if you could if you could document it and send it over, we can have the SS folks as well as potentially CHN look at it for appropriateness and guidance.
Yep, okay. I know we have submitted a request about the 02, 05, 02 F, the F codes, because if Medicaid system would accept those, that would be wonderful. So, and then just another question on what you explained. So if they're in the 3rd trimester by January, we would not do anything for October, November, December. And so we're not capturing that revenue at all, is what I heard. Is that correct assumption?
Those individuals would still be fee for service or global code.
Okay, so if they're in the 3rd trimester, keep them as a global code.
Yep.
Got it. Okay, thank you.
Yeah. Yeah. Or submit the fee for service claims that you would normally for that individual, but it sounds like those individuals would roll the global for you.
Okay.
If there are no questions, I have a question here. Tiffany, that I'll read. I'm not sure exactly what Christine is asking, but she can expound on it if she wants to. She says the Connecticut Department of Social Services, in the billing example provided online, the claim detail shows the delivery billed with the global code. Please clarify this. Thank you.
This is a follow-up to the response we received, and apologies, I like to listen to these calls because there's always different questions. So I was on yesterday's call and asked about billing globally at the end of the pregnancy, if we needed to bill those global codes, and I believe the response was no. But then when we went out to the website and pulled the maternity bundle examples, the example shows for the delivery codes, it's showing the 2 CPT codes. So it's showing delivery with 59510, and then it's also showing the 59025 in this with a with modifiers 26 and 51, both showing as zero pay, but it's showing in the bundled billing example as billing both. So we're looking for clarification on that.
Christine, I'm not sure if I fully understand your question, but I will explain or answer based on my understanding first. So we included those global code. You're right? So after the program go live, in order to trigger case rate payment, the only way to do so is by billing E&M code along the way, right? To ensure case rate. If you only bill global code, that will not trigger case rate, and that will just have the global code claim will be billed fee for service. But the reason we do include those cases is that, let's say, I don't know, basically we want to have a full list of codes that are maternal related, and that to indicate those codes will be reimbursed fee for service. And those codes are what we use to pick up historical experience to develop the case rate payments. So you will see both the individual delivery codes on the case rate code list, and then the global code on that code on the case rate code list.
So no, I understand on the case rate code list. This is I wish I could share the example, but it's the maternity bundle billing example. So it's not the code list that was published. It's the PDF that's maternity bundle billing example. It's that document where it's showing both the delivery and the 59510 and the 59025. They're both showing as zero pay, but they're showing it on that document. So I can, is it best if I follow up individually? I can share the example via email.
Yeah.
Yeah.
I think that
Okay. All right. I'll do that. Thank you.
Thanks, Christine. If there are no additional questions, oh, Colleen, please jump in.
Thank you. I had sent a reply back to Kim earlier today. In the E35 file example that you guys have provided, there were questions about, and this was answered for us, I think, during yesterday's call and again in an email, with questions that we had previously submitted, that the CARC codes that were being returned was a CO 119 and then the CO 245, which everybody agreed to that was going to be used, the 245 instead of the CO 97. My question is that the 119, the explanation of why you guys are sending 119 versus typically a CO 45 is sent, indicating that it's, because of the allowable, that, we build more than what the what your allowable is. I was just curious as to why the file is returning a 119 and why it just wouldn't return a CO 45.
I think this might be a question best suited for MedOps.
Yes, that's the code that we aren't making changes to how we're, what CARCs and works we're responding on other types of situations. So that's what we have always responded, and we're just not making changes to that one.
So every file that you send today, if the allowable adjustment doesn't come back with a CO 45, it comes back with a CO 119?
Anytime you bill greater than what our Medicaid allowed amount is and we cut it back to, yes, we are currently sending you a 119 with the difference. So if you billed $50 and we allow $40, we're sending you right now a CO 119 for $10.
Okay.
We didn't make any changes to that.
Even though that's maximum benefit, not contractual adjustment for the allowable.
Yes.
Okay. Any reason why you guys don't use 45?
That I can't answer that at this very moment. That's how we did it, whatever, 10, 12 years ago when we implemented CARCs and WARCs. And this is the first time anybody's ever questioned it in all the years that we've mapped it this way.
Okay, thank you.
Yep.
All right, I'm not seeing any other questions, but again, please raise your hand or enter them in the chat. We'll also reiterate, this is not your last opportunity to ask questions and get clarification on the program. Oh, Bernadette, please.
How exactly are postpartum charges to be submitted with E&M codes for the 90 days?
That might be a billing question we can take back. I would imagine just bill as whatever that service is. If I don't know, Cindy, if you have more to say about it.
Yeah, there are specific HCPCS codes that are specific to postpartum, and I think they are listed in the case rate list that we would zero pay.
Okay, so as long as the trigger code was submitted, they would be.
As long as the trigger code was submitted you know, even pre-delivery, as long as nobody else has triggered the episode to their
Their practice. different
practice,
day. Okay,
you wouldn't need to, as long as nobody else has triggered it, you don't need to submit another E&M code.
okay. Thank you.
And there are trigger event E&M codes for the postpartum period. So if you did need to re-trigger, you would certainly be able to re-get your case rate.
Yeah, I think there are different diagnosis codes that we would expect in that situation, since obviously you couldn't submit it saying that the client was whatever weeks pregnant. So there's specific diagnosis codes if you had to re-trigger that we would expect to see on the claim.
Any additional questions? And I'm assuming your hand is a legacy hand, or wanted to make sure if you check if you have another question.
No, we're all set. Thank you.
No problem. If there are no other questions, we'll go ahead and end the call here. Thank you again for your time and participation in this meeting. Like I said, this will not be your final opportunity to ask questions. You're welcome to email your CHN representative with additional questions. We are also happy to set up time to review your case rate or other questions you have about the program. And DSS and CHN will likely be hosting another provider forum or office hours in December before go live.
Thank you.
Thank you.